With regard to cholangiocarcinoma, cholangiocarcinoma can be divided into 3 groups anatomically. It's either intrahepatic cholangiocarcinoma, or pre-hilar cholangiocarcinoma, or ductal cholangiocarcinoma, or distal cholangiocarcinoma at the distal part of the biliary system. The bad things about this slide that we're not here. We don't have the real prevalence of cholangiocarcinoma in Saudi Arabia or in the Middle East at all. The commonest areas in the world that cholangiocarcinoma is being detected are in the Southeastern Asia, China, Hong Kong, and South Korea as well. With regard to epidemiology of cholangiocarcinoma, it's one of the least common gastrointestinal tumor and one of the least common malignancies. Less than 1% of the total malignancies represent around 3% of the gastrointestinal malignancies. It is the commonest biliary tumor after hepatocellular carcinoma in patients with liver disease. The overall incidence of cholangiocarcinoma has been increasing like all other types of cancer in the world, maybe due to more mutagenetic factors in the nature or in the food. It has some genetic association. In North America, it's associated with Hispanic population. And it's the other thing about cholangiocarcinoma that it's have some more male predominance, like primary sclerosing cholangitis and ulcerative colitis as well. The risk factors for cholangiocarcinoma are mainly primary sclerosing cholangitis, and this is the topic for the day. And about 10% of patients with PSC, they're likely to have cholangiocarcinoma. And hepatobiliary flukes like clonorks, which are flat worms that infected the biliary system. The thing that those type of flukes, they're common in Southeastern Asia. And this might explain the higher rate of cholangiocarcinoma in that part of the world. And bile duct, cholelithiasis as well. I'll come to another slide about risk factors. So, as I mentioned, choledochal cyst is the most common factor that's associated with cholangiocarcinoma. And the cholelithiasis, liver cirrhosis, and risk factors are B and C viruses, smoking for both extrahepatic and intrahepatic cholangiocarcinomas. With regard to the genetic association, there are several genetic associations. I think maybe Dr. Prof. Shadi will tackle on that make the management of those patients different. So some genes, they're associated mainly with intrahepatic cholangiocarcinoma. Some genes, they're associated with both intrahepatic and extrahepatic cholangiocarcinomas. And some genes, they're associated with mainly extrahepatic cholangiocarcinoma. And the slide shows also some genes that are associated with gallbladder malignancy. Most of the patients, they are asymptomatic. Unless they have obstruction, they would show the biliary obstruction symptoms, jaundice, stool and urine changes. And some patients, they have, with advanced disease, they tend to have some constitutional symptoms, like fatigue, abdominal pain, constipation, diarrhea due to bile salt abnormality. Patients with advanced disease, they might have ascites due to either to liver decompensation or to metastasis to the peritoneum. With regard to the intrahepatic cholangiocarcinoma, the diagnosis is based mainly on radiological diagnosis like CT scan or MRI, MRCP, and the lesion can be showed as either nodular. Compared to hepatic carcinoma, it does not show the early washout of the contrast in the CT scan, and will be also be seen in the venous phase. That's when you have 1 or 2 lesions that could be confused in patients with liver cirrhosis, PSC, to compare HCC to cholangiocarcinoma. The survival after surgical resection is not so impressive in patients with advanced cholangiocarcinoma. However, patients with early stage, they tend to have acceptable survival, 5-year survivals. I'll show another slide for that. The patients stage 2 and 3, they fall in between. However, most of the patients, they would survive to at least 60 months. Patients with stage 2 and 3 and stage 1. The factors that they're associated with advanced tumor, that the large tumor size, multiple tumors, and when we have local involvement, like lymph node involvement or local invasion, that makes the surgical resection difficult, so the patient will have ultimately worse outcome or worse prognosis. This trial was conducted on patients with cholangiocarcinoma, intrahepatic cholangiocarcinoma, and they used both patients with early cholangiocarcinoma and patients with advanced cholangiocarcinoma. And they showed that patients with early cholangiocarcinoma, they do better on the long run, with 5-year survival, promising 5-year survival of around more than 60%. However, patients with advanced tumor, they don't do much well. They have about 45% 5-year survival. Okay, other modalities that can be used for intrahepatic cholangiocarcinoma, but they're not so promising, are the local regional therapy. A test is being used, and it's not so promising, at least in the data that were prepared by Dr. Faisal. The other thing, TER, can be used, and it showed some promising data in improving the overall survival and the disease-free survival in some of the patients with non-resectable tumor. So in patients with intrahepatic cholangiocarcinoma, so if the patient is resectable, he has to go for surgery, for resection. If the patient is non-resectable, we have two ways. If the patient is a candidate for local regional therapy, we would go for local regional therapy. If the patient is physical status is stable and he can tolerate that. If the patient is physically unstable, the patient status is very poor, he would go only for supportive management. If the patient is not candidate for local regional therapy, we could go for chemotherapy, immunotherapy, and radiotherapy in some patients, and all those are not so promising until now, but we will come to some of the immunotherapy. With regard to the prehilar cholangiocarcinoma, again, usually the presentation is painless, jaundice. However, some patients, they might present with complications like cholangitis, ascending cholangitis, and some constitutional symptoms as well. As we said, that these tumors are they present usually late. CA19-9 might be elevated, or it's mostly elevated in those patients. And again, we depend on the radiological diagnosis for those patients: CT scan, MRCP, ARCP with cytology, or AUS with cytology as well. These are pictures for the tumor. This is the histopathological presentation of the tumor. The way the gland is showed, they're so dysmorphic glands, and they have large stromal material within the tumor. This is the cytology of the tumor. Sometimes the cytology, in the hand of the expert pathologist, cytology obtained with the EUS or with the ERCP can tell the diagnosis if you have enough tissue in that. So these are the positive malignant cells. These are where you cannot really differentiate because of atypia and suspicious areas, and so you may need to repeat the cytology in some patients. Cytology is good as a tool, but it has its own limitation, but it's the tool that we have in our hand at least to reach to that area to obtain tissue histology or tissue biopsy. The diagnostic criteria in cytology is not very clear, and I said the expert pathology or the expert GI pathology will be different from non-expert or general pathologists in getting the diagnosis. However, when you have a positive cytology, that's very good because it has very high specificity. With regard to the fluorescence in situ hybridization test, it's a radiological tool that is much less compared to cytology, but it's a good tool if you don't have the expert pathologist because it has high specificity that's very close to the cytology. However, it's very sensitive. That means it might give a lot of false positive results. So, another diagnostic test that we could use radiologically is the PET test, but it has less sensitivity and less specificity compared to the FISH test and compared to the cytology. So it's not, I would not recommend it for that. I don't know about the oncologist. So for prehilar structure that IgG4 negative, that might mimic cholangiocarcinoma, we do the cytology and the biopsy, or the biopsy. If it's positive, we're all set and we go to the management. If the cytology is negative or the FISH test is negative, we look at the CA19-9. If it's elevated, so it's probable, and we may need to repeat. We don't need to repeat the cytology. If the CA19-9 is normal, then we have to repeat the ERCP or the EUS and obtain another cytology. If it's positive for all sets, if it's negative, we could just follow the patient with MRCP as screening every now and then, surveillance. With regard to pre-hilar cholangiocarcinoma treatment, all cholangiocarcinoma type, just to take, it's surgically treated. If the patient is surgically unresectable or untreatable, we'll use the alternative mode of modalities or the alternative modalities of treatment. And sometimes with pre-hilar cholangiocarcinoma, the resection is difficult because of local invasion to the biliary system or to the lymph nodes or to the liver tissue itself or to vascular organ close to the hilum. So that's making the patient unresectable. And the other thing is the tumor size that would affect the outcome of the tumor or decision for the surgeons. Bad, or what we could say, bad prognostic features for pre-hilar cholangiocarcinomas are when you have bilateral involvement, or you have what they call bilateral contralateral hepatic artery or portal vein involvement or enhancement, and intrahepatic extension of the tumor, or when you have stage 4 distal metastatic tumor. That makes the tumor unlikely to be resected as well. So the survival of post-operative pre-hilar cholangiocarcinoma is not really so promising in advanced disease. However, that's when you have lymph node involvement, the survival will also be diminished or reduced. This is the survival following liver transplant in a trial that used 270 patients. So, I think.
Excuse me, Dr. Hind. You have 2 minutes left on.
Sorry. Okay. I don't know. So with the pre-hilar cholangiocarcinoma, it will be more or less the same. However, so just to summarize, for cholangiocarcinoma, the clinical presentation, usually the patient is silent unless they have obstructive features. Radiological diagnosis, CT scan, MRCP, ERCP, and cytology or EUS, that diagnostic tool. The outcome is not so promising. However, some of the medication that could be used in those patients are the cisplatin, and several trials are being conducted, phase 3 trials. I think Shadi will know about that more than me. The phase 1 trial that using the, this trial is being conducted for the last 3 years. I think they published this abstract recently. They're using the durvalumab with the, sorry. I missed it. Yeah, they use with the gemcitabine, and it showed better outcome compared to gemcitabine alone for both disease-free survival and overall survival. The diagnosis for distal cholangiocarcinoma is the same, and these are some of the ongoing phase 3 trials on several medications throughout the world. Some of them, those are done on patients who are surgical candidates. So we're going to have future treatment that depend both on immunotherapy, chemotherapy, plus surgical resection that might improve the mortality in the future. I will run. So I will just stop at this point, and that's it.